first of all, I will say that I am not South African. I have been introduced before in giving a talk of this sort by someone offering a prize for those who can guess where my accent comes from. None of you would know. All right. I'm going to talk about something that's actually very different, or I think is sort of over the horizon for most of those thinking of the AIDS epidemic. And really I'm going to be talking about those children, largely those children who are not HIV infected, but are experiencing their parents being HIV infected, and in some cases, their communities being HIV infected. So I'm going to illustrate the extent to which the AIDS epidemic has contributed to children becoming orphans. I'm also going to discuss the psychological effects of parental HIV disease on children. I'll describe some of our own research, and I'll say right now that some of this data is literally coming across from South Africa right now. So some of these slides I did make up last night. So I give excuses beforehand for saying that we're not complete. And then I'm also going to discuss the growing evidence that uninfected children born to HIV-positive mothers are doing poorly. So these are not the infected children. These are the uninfected children. This slide shows the number of children estimated to be orphaned by the AIDS epidemic in sub-Saharan Africa. And as you can see, the tremendous increase since the early days of the epidemic, going up to 2010, of over 15 million children. And this is what it looks like when put on the map, that here we see 1995 compared to the year 2005. And these darkest areas are those where more than 15% of the children, so that is 1 in 6 children, has lost a parent has lost a parent. This is for all causes of orphaning. And as you can see, in the early days, it was these countries in Somalia, Eritrea, and over here in Liberia, the countries that were obviously in conflict at those times, where you see the high numbers of children being orphaned. Whereas now, or this is in 1995, so sorry, 2005, so we'll even have changed by today. You can see that it's these countries down below here that have over 15% of their children are orphans, meaning having lost either one or both parents. And obviously this is largely due to HIV disease. And this shows country by country, with on the darker blue there the numbers of orphans being orphaned by AIDS, all other causes. And as you can see, in a country like Zimbabwe, they had a rather low level of children being orphaned until AIDS came along. And then AIDS contributes to, by far, the majority of those children who are orphaned. As opposed to another country such as Rwanda here, or Cote d'Ivoire, where other causes have contributed to the numbers of orphans, whereas AIDS plays only a smaller part. This shows the age distribution, and here I point out that the common terminology is single orphans and double orphans, meaning having lost both parents. And on the left, you can see those that have lost just one parent. And then, obviously, at a slightly older age, meaning that it takes time for both parents to die. I'll point out straight away from this slide that if a parent can be kept alive for another 10 years, say, what a difference this slide would look like as far as the numbers of children being orphaned at early ages. So right here, you see about a third of the children having lost both their parents by school age, by 11 years old, and how that could be shifted if we can keep parents alive. Now I'll turn to South Africa. Prevalence rate among adults, 17.8, and like other countries in sub-Saharan Africa, it's more prevalent among women than it is among men, usually about 60-40 or 65 35 as far as prevalence rates go. So obviously women are largely are affected to a greater degree. And in South Africa at the moment, South Africa with a country coming up to a population of about 50 million, that you have 3,300,000 women who are infected, and coming up to 2 million children who are already orphaned by the disease. The adverse effects of on AIDS orphans are basically multifactorial. Diminished psychological well-being, and here the stigma of the disease plays a major effect. These families, for the large part, are living in what's been termed emotional exile. If they can't turn to others to tell them about their HIV disease and can't speak about it within the family context, within the home, how is the child going to respond when children are able to know when there's a big secret, particularly a big secret when one of their parents is apparently ill, but no one's talking about it? All of these things have been reported in different studies. The depression I'm going to speak more about, the bullying of these children because of they're stigmatized, increased poverty. Here I refer to child-headed households. This is where 15-year-olds are looking after their younger siblings within a family where there is actually no adult. The skipped generation households. If a grandma takes in the children of her oldest daughter and then has to take in the children of her youngest daughter, and then the money for that, the income for that family is just the same or perhaps less, because she is now less able to go out and work to bring more income in, then the poverty goes down tremendously for that family. Poor school performance and early dropout rates, well documented. There's a gender difference here. Girls are affected more than boys because it's felt that the girls should be in the household, helping others, helping run the household when there's no mother to run the household. There's a gender difference to a number of these. Girls do not get a good rap as far as when they are orphaned. Decreased access to healthcare and other services. And then the last one, perhaps concerning very much for the next generation, is that these children are more likely to get STDs and HIV. And this has been documented in this country as well as in Africa. Talking about the mental health of these children, this was a good review article that came out in 2009, where there were 24 studies worldwide, 19 in Africa and 5 in the US. All of them were cross-sectional, all except 2, sorry. And there's a wide variation in how they measure things and everything like that. So they're not really comparable across from one study to another. But the results show that externalizing problems, and just to give you some of the language that we pediatricians and child psychologists will use, externalizing means it's basically acting out behaviors. Internalizing problems are those where withdrawn, depressed, anxious, so less likely to show that they're having a problem. So the results of these studies are that basically most of them show that these children have externalizing problems, and some of them show, or half of them show, that they have internalizing problems as well. But the summary of this review was that more longitudinal studies, or studies with a control group of children living with caregivers who are ill with AIDS, are also necessary. In other words, we're focused on the orphans, but we're not focusing on those children who yet are possibly going to become orphans, and are already perhaps experiencing, or do we know if they're experiencing, the ill effects of this disease? Sorry. This is one study that actually did that, and I'll say first, I'm very struck by the numbers of study like this, but it comes from HIV, parents with HIV and their children in rural Chinese children. So very large study. And here the orphans are in the blue, the vulnerable children, that's also a term we use for the children who are not HIV infected but living with HIV infected parents. Orphans and vulnerable children is the OVC is now the acronym that it's used. So these green ones are the vulnerable children and the blue ones are the comparison children. And as you can see, when you look at depression, for example, the orphans are the ones that came out highest as far as being depressed. But then if you look at the loneliness and self-esteem, loneliness is the vulnerable children that were significantly higher in loneliness, this measure of loneliness. And it's the vulnerable children that had lower self-esteem than the other two groups. Perhaps this has something to do with the stigma of the disease and what these children are living with in a family where the parents are HIV infected. The interventions for orphans and vulnerable children are very varied. The literature is replete with all sorts of different types of interventions. And generally, they're either center-based, meaning that children come to some sort of center or sometimes live in a center, but more often come on a daily basis or a weekly basis to a center. And there's all sorts of programs like art therapy and things of that people have done with children. Then there's community-based, and obviously this is where most of the effort goes, where there's all sorts of interventions within a community and a community rallying around the needs of the children within the community. So here I've said about psychosocial support, groups, home-based care, legal protection, things like the inheritance rights. Once again, girls, if their parents die, have no rights in some countries to the land that was owned by their parents and farmed by their parents. Things like child-headed households. This is something that was addressed in South Africa. Child-headed households couldn't get the same sort of food, social security type things that adult-headed households could get. They had no place there, and so there was a need to change the law to basically allow these children to be able to get the same sorts of grants and such like. Educational assistance, economic incentives, this has been shown to be effective, putting money into a child's own banking, if you like, so that that child is able to go to school and doesn't have to work and all those sorts of things. So a lot of different types of interventions. But are they effective? In 2008, obviously people like UNICEF and USAID are very interested in knowing, is all of this working? Because a lot of the funding is coming from sources such as this. 414 studies reviewed, 3 systematic reviews, 16 randomized controlled trials, and 64 with control groups. Their summary was the evidence base on effectiveness and efficiency of interventions is almost non-existent. Another study that came out the following year, 21 studies involving community interventions. Although findings overall indicate the value of community interventions, the quality and rigor of the evidence is varied. And then a Cochrane collaborative. You can always depend on the Cochrane collaborative to be the most stinging or the most critical. And here they looked at 12 studies that as potentially relevant and came up with saying 0. None of these studies really was good enough. And so this systematic review has identified the need for high-quality intervention studies, obviously laying the way for what I'm going to be talking about with our own work. All of these reports actually came out before we started the study that I'm going to speak about. Okay, for some reason. All right, there is one study that I really want to give a little bit of time to, because it's perhaps the very best study. I shouldn't say perhaps, it is the very best study in looking at this sort of thing. And it's done by Rotherham Burris when she was still in New York, Mary Jane, and in the fairly early days of the epidemic. I point out that these are parents with adolescents, and all the adolescents here were aware already of their parents' HIV status. So it really doesn't translate into what may be going on elsewhere. So a randomized controlled trial. They basically had all day Saturdays would they spend on this, and so they had 4 Saturdays with the parents alone, and then 8 Saturdays where the parents and adolescents were together. And they followed them up every 3 months. And they did show a significant effect. This is the intervention group is in the solid line there, and the comparison group in the hatched line. And you can see that when you talk about behavior problems, they came down, conduct problems came down, family stressful events came down, and self-esteem went up. So quite a success at 2 years following. I was impressed that they were able to do a 6-year follow-up on this group, and they showed some positive effects at 6 years. The intervention adolescents, these are the adolescents now, are more likely to be in school or employed. They are less likely to be a parent, and they're less likely to have somatic symptoms. Although you can see that as far as grief inventory and overall symptom inventory, there were no difference. And I also have to say, they looked at a whole lot of things and came up with only a few positive effects at 6 years later. But I give them all credit for having tried. So just give you a little history. In New Haven, we started, this was with Jean Adnipose from the Child Study Center and myself, started a family support program for children with AIDS. I couldn't remember whether it was 1988. I just know it was before 1989, but one of those years back there. We got funding first ever from the Paul Newman Foundation, very early days of the Paul Newman Foundation. Then we continued to get some funding for that program. This was a home visitation program, almost a home preservation program, helping these families not have to put the child into foster care. And this program evolved into Connecticut Ryan White program, and it still continues today, with services in the program providing in New Haven, Hartford, and Bridgeport, and at one time in Stamford, although the need there became less. And in Pretoria at the same time, the work I was involved with, we had already done an intervention providing support to women who found out in pregnancy that they were HIV positive. So this was a 10-session group sessions support program. And we did show some effect from this program. You'll notice some names here of people involved. Trace Kershaw was involved with us in this program. And Jenny Macon, some of you know from her visits here. I'll say right now that a major part of this project, this older project, was getting the women to come to the groups. Very difficult thing that I will refer back to as you see how poorly we did in the study I'm about to present. The study, whenever I do something in South Africa, they come up with a yet more difficult name for me to pronounce. So this is the Holomogo project. Randomized clinical trial, HIV-infected mothers and their uninfected children who were younger, these 6 to 10-year-olds. And you can see the aims were to demonstrate the effect of parental HIV disease on young children, first of all. and to assess the efficacy of a theory-based support intervention for improving child outcomes, so-called building resilience. This is the idea. If these children are going to suffer the death of their parents later on, can we do something earlier on to build strengths in these children? There is no measure of resilience, incidentally. So we're obviously using other behavioral and psychological outcomes here. We also wanted to identify maternal, psychological, and medical factors that contribute to changes in child outcomes. Now, I'm not going to speak about that at all today because, in fact, some of those data we have not yet analyzed. The children were enrolled at an AIDS clinic. This is the major teaching hospital of the University of Pretoria, and also at primary care clinics in the area. Tshwane is actually the new name for Pretoria. The mothers were all HIV positive, and all the children were HIV negative. Some were tested, most were not, but we had, or I should say they had been tested earlier in life. Support group interventions for both mothers and children. And I'm going to speak a little bit more about that. This is not just support groups for mothers, it's support groups for young children. And we conducted evaluations at baseline, 6, 12, and 18 months later. We originally were going for 24 months later, and I wish we had, but we essentially ran out of time because the amount of time it took to do all the development work. And we also did a baseline comparison with children of HIV negative mothers. So this wasn't providing any service or intervention. This is, let's see at baseline, how do these children differ from children of uninfected mothers? This is our schema for the groups. And here, for the mother sessions, these are focused on the mothers. These are women who have really no other services in the area. There's really, strikingly, very little for such a large problem and such a large number. Very little. So we felt we can't be addressing the needs of their children until we first address their needs. So this was largely based on the earlier program. Then there were sessions on parenting, the needs of your child. At the same time, we were doing sessions with children, and I really give my colleagues a lot of credit here for the way they were able to work with children. This is manual driven. We have the objectives, I'll show you in a minute, everything for each of these sessions. So there's a real objective with the work with the children. And then, interestingly, the last groups were together. And you can see there's things like, this is largely on communication and interaction. You can see things like this, creating a legacy by developing a memory box. This is something that has been used culturally in Africa before. But the idea of keeping your parents alive, in a way, or your parents' memory, by putting those important things into a box. So obviously the selection of the important things is something that is important. Cultural adaptation and translation, this is when I was referring to, we got started a little late. Cultural adaptation and translation of instruments into 4 different languages and back translating. So here we are using US instruments to assess these things. And we have to use these US instruments with young children who, some of the statements or questions in these instruments are completely useless. There's no way you can translate this and it be appropriate for a child. It's all about, riding your bicycle and things like this. The piloting of the groups and the preparation of the manuals. As I said, each one has an objective. There's always an icebreaker and there's activities. Each group finished with singing of hymns, which I thought was interesting. And then training of the group leaders. These are not professional group leaders. These are what we wanted to happen out there in the community if we ever had the opportunity to take this out in the community. A lot of these group leaders were women who were HIV positive themselves. Some of them came from an earlier study we had done. So I'll go through this very quickly, but essentially we measured for the mothers depression, support, coping, and their experience of violence. I'm not going to go into these too well, but obviously we wanted to impact on parenting. So these are a couple of, this is very commonly used, this not so commonly used scales. And then the child outcomes. The child behavior checklist is by far the most commonly used instrument that's used. So here with our cultural adaptation and our translations into 4 different languages, we're using that. The Vineland was actually developed here by Sarah Sparrow and Dom Giacchetti many years ago and has become quite an instrument for assessing adaptive functioning of children. How well are they doing in different areas? So one's behavior, one's more like development. And then we also were asking these children, or at least the 7 to 10-year-old children, about depression and anxiety. And I'll say right now, unfortunately, I haven't got to doing any analysis on these yet. This was the first thing, comparing these children with their children of uninfected mothers. And I've jumped a few slides to give you this information to move along. But here is the uninfected mother, or child of uninfected mother, I should say. Here's the non-symptomatic HIV mother, and here is the symptomatic HIV mother. And clearly, it's not the mother being HIV infected, it's the mother being sick that is the difference for these children. Once again, I'll say it again, I'll keep on plugging this. Keep the mothers healthy. There has been some modeling on the effects of children having problems and what that might make for the next generation and the one beyond. But if you're affecting 25% of the children, if 25% of the mothers are positive, then it's a huge issue. Okay, and here's our randomization, basically. You can see the mother's average age was 33. The majority are either married or with a partner, but there's obviously some who are not with a partner and are single-parent households, or I shouldn't say single-parent households, but single parenting. They were similar. The majority had a secondary degree education. The one difference was that the intervention group were less likely to be employed. The housing score is something that we've used now for a number of years that we made up, but it's basically, do you have electricity in your house? Do you have a roof? Do you have a fridge in your house? Do you have a phone? Do you have running water? Running water being the major one. Down here, you can see that these intervention mothers were a little less likely to be symptomatic. So all of these variables were entered into further analysis. Sorry, the variables where there's differences. And the other difference you see here, really connected with this, is the reason for testing was that these mothers tended to be ill. I point out this here, because the average age that these women had known themselves to be HIV infected was only about 2 years. Now, when you think about the growing up in the life of a child, and the mother's only known for 2 years, obviously most of the child's growing up experience has been before this. So I sort of emphasize that right now. For the children, they did, unfortunately, they were slightly a little bit younger in the intervention group. And you can see that very low numbers as far as knowing that their mother was HIV infected, or I should say having been told that they were HIV infected. We also asked things like, do suspect that your child knows. And it wasn't too much higher. They had known an HIV positive, so that's about 1 in 6 of these children had known an HIV positive person who had died, and smaller numbers for someone really close to them, meaning like a family member. This is the unfortunate part of this whole study. In our intervention group, a quarter of the women didn't even show up for the first session. Another quarter didn't come to more than half the sessions. And so we're only left with about half who came to more than half of the 24 sessions. This is despite the fact that we gave meal at every, it was a very social event, these, and paid for their transportation to get there as well. So like the earlier study, this is almost identical when there were support groups for mothers. They mostly couldn't or didn't want to get there. And of course, we really don't know which of those. I will say that sometimes we had the children come and not the mothers, and sometimes we had the mothers come and not the children. And we haven't yet looked at what happened when the children came. And this is the sort of effect that we see. So here, all of these slides from here on, I'm only looking at those 50% who came to sessions, who came to at least half the sessions. And these are the sorts of effects. These are T-scores on externalizing behaviors, and you can see that it looks like they were doing better. Not so good with the internalizing behaviors. But when we get to looking at the girls and the boys separately, we are seeing some effects. Now here, this is the child behavior checklist. So a high score is a bad score. It means you've got more behavior problems. And you can see for the girls, the total score, externalizing score, was significantly improved. I'll say that for all of these, you can see that the blue lines are lower than the green lines, meaning doing better. And this was significant for the total externalizing behaviors, as well as decreases in aggressive behaviors, decreases in attention problems. So this is controlling for all those others in the mixed linear analysis here. And you can see that even though there wasn't a significant difference on the total externalizing, these boys also had decrease in attention problems. And on the internalizing behaviors, once again, we see the same pattern, perhaps not so striking down at the bottom here, but for the girls, almost significant at the total internalizing problems, but anxious and depressed, less problems demonstrating anxiety and depression, and similarly for the boys over here. Okay. So some improvements in children's behavior over this 18-month period. And adaptive functioning, and this perhaps surprised me more, that's where we're seeing the biggest change in communication for both the boys and the girls. These here on this scale, the blue is, all of these is improved development to be higher. Higher scores are better. So we're seeing significant improvement in communication, both for the girls and the boys. And remembering that a major part of our intervention was around that communication between parent and child. And here you can also see that as far as the boys did, they also had improved socialization. So the summary of the results to date, there was little effect on maternal, psychological, and parenting variables. I haven't shown you that. I've slid past that. But there were significant effects of the intervention on child outcomes. Girls improved on all the externalizing behaviors, while boys had only a decrease in the attention problems. Boys improved in total internalizing behaviors, and both boys and girls exhibited a decrease in anxious, depressed behaviors. And in adaptive functioning, both boys and girls had significant improvement in communication, and boys also improved in socialization skills. Might this contribute to resilience? Obviously, we're not sure. The conclusions, though. Poor attendance is a major drawback for a center-based intervention. And for those who attended more than half the sessions, the intervention did have a positive effect on child functioning and behaviors. And there was some difference, and there are differences between boys and girls in those improvements. But obviously, we have a lot of work to do and more analysis required. The potential effect of more complete attendance are, I showed those that came to at least half the sessions. That means 13 out of 24. We haven't looked yet at what if they came to almost all of them. And quite a few did come to almost all of them. So we want to look at that too. But we're going down to very small numbers. These were not the numbers that we did our sample calculations on at the beginning. We also haven't looked at what if they came to all the parenting interventions, all the parenting sessions. Forget those early sessions and just come to the parenting sessions or the parent-child interaction sessions. Were those the ones that perhaps had the most beneficial effect? And we haven't looked at the child's attendance at any of these sessions either. This differences in child gender could be of some importance. Should we be doing something differently with girls than we are with boys? And we haven't looked at the child-completed measures that I spoke of before to see whether they're reporting improvements for themselves. And obviously, we haven't had time yet to look at the potential moderators, like if a mother's ill, does that have a greater effect than if she's not ill? So I'm going to switch a little now, and I am watching the clock at the same time and want to give you time to ask questions at the end. I'm going to switch to talk about what's now termed the HEU infant, the HIV-exposed uninfected infant. So there I'm talking about children who were known their mothers had known they've been infected for the last 2 years. We don't know how many of those children the mother might have been infected when she gave birth. But these are the children where we know the mother was infected and during the time that this child was in utero, was during her pregnancy. And just to use South Africa as an example, with the successive efforts to prevent transmission from mothers to children, transmission rates have now come down from about 40 to 50% of the children of these mothers being infected to about 5%. That's the good programs that are 5%, it's 10%. In an area where 25% of the pregnant women are HIV infected, such as the Pretoria region, in other regions it's 30%, it's even more. About 1 in 4 babies are now in the country are now being born HEU, HIV-exposed uninfected. And the recent literature is describing that these children have increased mortality, increased morbidity with serious infectious illnesses, poorer growth, and question about developmental delay. In fact, there haven't been really good studies looking at these children's development. Here's just an example of a paper that summarized some of the data on mortality of these children. These big numbers are the N's in the group. The light gray there are the HEU, HIV-exposed uninfected. And then this is the mortality by a percent, so out of 100. So you can see that for each of these studies in all these different countries, the HEU babies, the HIV-exposed uninfected babies, had an increased mortality rate compared to their non-exposed peers. I've taken this diagram, adapted it from the previous paper that you saw. And the reasons for this The bottom line is no one knows yet. All sorts of things being explored. Obviously, HIV exposure, the mothers are not as healthy. They may be exposing their children more to infections. They may not be breastfeeding as much. That may affect the child. That affects the mortality. Over here, the other abnormalities in the immune systems of these children, and there's certainly papers to suggest that. And here I just show one of them. This is the transfer of maternal antibodies from the HIV infected, shown in these dark circles, and the non-HIV shown in the open circles. This is antibody responses to common infections like pertussis, Haemophilus influenza, and you can see that each of them, there's a significant decrease in maternal transfer of antibodies from the HIV positive mother. I'm going to add one more in here, maternal depression. This comes from earlier work that we've done showing the rates of depression among women who, in their early period, this is from pregnancy. These rates, now this is the depression score here, but this is about 44% of women in pregnancy, having just found out that they were HIV positive. 44% of them were classified as depressed. Now, it did go down after they had their wonderful new baby, but 18 months later, it was back up where it was before, as far as the amount of depression that these women were experiencing. And then this comes from studies having nothing to do with HIV infection. These studies are looking at maternal depression, all different studies, some of them measuring depression in pregnancy, some of them postpartum depression, and looking at children's growth, relationship between depression and children's growth. And you can see the relative risks for all of these studies is, for most of the studies, quite powerful, meaning that women who are depressed in these poor countries are more likely to have a baby who isn't growing well. And what I didn't tell you about the Holomoho study is that we also invited mothers of 3-year-olds to come into the study. Now, these happened to be babies in an earlier study that we followed from pregnancy, where they had been given no intervention. And some of them were still coming to the research center. So we invited them to also be part of the project, although recognized that we wouldn't get all that many of them to come. And this is the 35 HIV positive mothers, and we also looked at some HIV negative mothers, or children of HIV negatives. And once again, this is the Vineland, and you can see that these children are severely down in their daily living skills. The standard for this is 100, at least in a US population. 100 would be a perfect score. So these children, children born to HIV positive mothers, were having more problems with daily living skills, decrease in socialization, and also had more externalizing behaviors in the same way that I spoke before. This was quite a bit different than the older children. The older children weren't as bothered, didn't look as bad as this. And so here we have 3-year-olds whose mothers have known they're positive from before they were born, and they're not doing well. We were surprised. This is another analysis that we did with our baseline data from Holomoho, and it's very complicated. I'm really just going to bring your attention to the fact, something went wrong in going from a Mac to this. That did say parenting. You can see that when you look at this without parenting in the middle, there's a very weak relationship between some of these outcomes and depression, maternal depression. But when you put parenting in the middle of it, depression and coping for the mother affect their parenting distress. And these factors affect the things that we're measuring in child outcomes. So it speaks to the fact that this HIV-positive mothers, parenting is an issue affecting their children. Their ability to parent. So where do we go next with all this? My first question is, do HEU children have poorer development than children who are not HIV exposed? And we actually have a medical student in South Africa right now who I'm not sure he wanted to train on doing child developmental evaluations, but he's doing a pretty good job in doing the assessing children's development for those who are HIV exposed children and non-exposed children. Then there's the question of what contributes to poor outcomes of these HEU children, that big, busy slide that I show you. And the question of maternal depression. And at the same time, we do have a project where we were, by chance for something else, following women until 3 months post-delivery. And so we're now measuring depression. That's the time when it should be best. But perhaps also that's the time that if they are depressed at that stage, that's most likely, if they continue to be depressed, affecting their parenting and their abilities to look after their children. Is it the in utero environment? And we've started doing some work, doing cord blood specimens, looking at different markers of inflammation. Is it because these children start out differently from the beginning? Or other, and as I say, that there's quite a bit of interest at the moment looking at different things, obviously with the hope that if these 25% of children being born now in South Africa are going to be affected, is there a way that we can address this? Would treatment of mothers make a difference? And then in thinking about the whole thing of intervening with children, I'm more prone now to think about intervening with the very young child. Those measures on 3-year-olds are bothersome to me. And if we're really going to build resilience, then I think we have to start early. And I think it needs to be a home visiting component because of our inability to have people. So it's going back to our original program that we had here in New Haven, where it was all home visiting. And for the focus to be on parenting, helping parents feel more comfortable in looking after their children. So final conclusions, that I think a lot more work needs to be done to understand the potential effects on HEU children. And I'll say yet again that I think children can be helped most by keeping their parents healthy. Another reason to start antiretroviral treatment early. And probably, I think it'll show that treatment in pregnancy is what they need to prevent these outcomes. And I go back to this slide, which I've shown you before, that it's the symptomatic parents who have poor outcomes for their children. Thank you.